This video presents a single-port robotic ileostomy reversal with iliotransverse anastomosis, performed using the Da Vinci SP platform. The patient is an 82-year-old female with a medical history significant for hypertension, hyperlipidemia, and type 2 diabetes mellitus. 4 months prior, she underwent an exploratory laparotomy, right hemicolectomy, and ileostomy due to bowel ischemia. Her postoperative recovery was uneventful, and she was subsequently scheduled for robotic takedown of the ileostomy utilizing the SP system, as demonstrated in this recording. In addition to the surgical kit that is regularly used for robotic procedures, the following set is shown in the picture from top to bottom. This includes Richardson-Eastman retractors, Vera's needle, Mayo scissors, clips, 5mm laparoscopic port, laparoscopic suction, and the SP access port. The patient's abdomen is prepared and draped in standard sterile fashion. The end ileostomy was mobilized by careful open dissection around its circumference, extending through the fascial layers until the ileum was fully freed, pulled forward, and transected. A small-size single-port access device was introduced via the existing skin defect at the ileostomy site, thereby obviating the need for additional skin incisions. The robotic surgical system was then docked on the patient's right side. As demonstrated in this segment, the procedure begins with meticulous dissection to separate the ileal-omental fat from the parietal peritoneum. Bipolar scissors are employed to facilitate precise dissection and early control of potential minor bleeding points. Adequate counter-traction is achieved using a laparoscopic grasper, ensuring optimal visualization and tissue handling throughout the maneuver. Dissection then continues in a deliberate and systematic fashion, aided by the superior visualization provided by the robotic platform's high-definition magnification. This enables accurate delineation and seamless dissection of the avascular plane between the mesenteric fat and parietal peritoneum. The distal ileum on the one end and the readily blind proximal colonic end from the previous surgical procedure are intended for the future ileocolic anastomosis. These are meticulously prepared through careful dissection of the adjacent omentum and any surrounding adhesions. To facilitate optimal alignment and stabilization of the anastomotic ends, plan to be constructed in a side-to-end configuration, holding sutures are strategically placed. These sutures not only secure the bowel segments but also provide a controlled and safer means of applying the necessary traction to position the bowel in accordance with the surgeon's operative preferences. Following the preparation of the anastomotic bowel ends, energized scissors are utilized to create precise and controlled enterotomies. These incisions are carefully fashioned to facilitate the smooth and accurate insertion of the stapler jaws into the designated sites for the ileocolic anastomosis. Once the stapler is deployed and the anastomosis is completed, attention is turned to the closure of the residual enterotomy. This is accomplished using a meticulous double-layer running suture technique, ensuring integrity of the closure. At the time of the procedure, the robotic single-port SP stapler had not yet been released for commercial use. Consequently, a laparoscopic endo-GIA stapler was employed to construct the anastomosis. Typically, the stapler is introduced through an auxiliary channel within the SP access port. Given the spatial constraints and ergonomic challenges inherent to this approach, the presence of a skilled bedside assistant is essential to ensure safe and effective stapling. Suturing is performed in a consistent pattern, maintaining a 0.5 cm distance from the edge of the enterotomy and between each stitch. Particular care should be taken at the dorsal corner of the common enterotomy, as it represents the most visually challenging area of the closure line. Therefore, we recommend initiating the closure at this point, proceeding ventrally and then reversing direction to complete the approximation using a double imbricating layer, as illustrated in this section. The fascial layer at the ileostomy site is carefully approximated using 2 running 0 PDS sutures to ensure secure closure and reduce herniation risk. The skin is cinched circumferentially with 2 to 0 vicryl sutures to optimize apposition and support healing. A wick is placed within the wound to promote drainage and minimize fluid buildup or infection.